Hello and welcome to our new topic on antibacterial drugs that work by inhibiting bacterial folic acid metabolism. Bacteria must synthesize their own folic acid, whereas humans obtain folate from dietary sources. This difference provides a selective target for antibacterial therapy. So, let's start. The learning objectives of this lecture series are listed here. Please take a look. Antibacterial drugs work by targeting structures or processes that are essential for bacterial survival. The bacterial cell wall is targeted by drugs such as penicillins. Protein synthesis is targeted by drugs such as macrolides, and several other groups. Nucleic acid synthesis can be inhibited by drugs such as fluoroquinolones and rifampicin, which interfere with DNA replication or transcription. The bacterial cell membrane is targeted by polymyxins and a few other agents. Finally, the pathway that concerns us today is folic acid synthesis. Sulfonamides and trimethoprim inhibit different steps within this pathway and thereby prevent the production of compounds that are essential for DNA synthesis and cell division. Notice that folate synthesis is a metabolic target rather than a structural target. Instead of damaging the bacterial cell wall or membrane, these drugs starve the organism of essential biochemical building blocks needed for growth and replication. Bacteria synthesize folic acid from precursors para-aminobenzoic acid and pteridine to form dihydroteroic acid, with the help of the enzyme dihydroteroate synthase. This is then converted into dihydrofolic acid and eventually into tetrahydrofolic acid by the enzyme dihydrofolate reductase. Tetrahydrofolic acid is the biologically active form of folate. It serves as a carrier of 1 carbon units that are required for several critical biosynthetic reactions involving synthesis of DNA bases including purines and thymidine, as well as the amino acid methionine. Therefore, when folate synthesis is inhibited, DNA replication becomes impaired, cell growth slows down, and bacterial division is inhibited. The key point to remember is that bacteria synthesize folate, whereas humans largely obtain preformed folate from the diet. This difference forms the basis of selective toxicity. At first glance, this slide may appear complex, but its purpose is not to make you memorize every enzyme or intermediate. Instead, it demonstrates how central folate metabolism is to the life of a bacterial cell. Folate participates in multiple interconnected pathways collectively known as 1-carbon metabolism. Through these pathways, tetrahydrofolate donates carbon fragments that are required for the synthesis of purines, pyrimidines, amino acids, and several other biologically important molecules. In bacteria, folate derivatives even contribute to initiation of protein synthesis through the production of formal methionine, which is used as the first amino acid in newly synthesized bacterial proteins. The take-home message from this slide is simple. Folate metabolism is connected to DNA synthesis, RNA synthesis, amino acid metabolism, and protein synthesis. Therefore, blocking folate metabolism has widespread consequences for bacterial survival and multiplication. Now let us examine folic acid more closely. Folic acid consists of 3 major structural components, including pteridine ring system, para-aminobenzoic acid, or PABA, and glutamic acid. Among these components, PABA is particularly important because it serves as the target exploited by sulfonamide drugs. Sulfonamides are structural analogues of PABA. In other words, their chemical structures resemble PABA sufficiently to fool bacterial enzymes. Normally, bacteria use PABA as a substrate for the enzyme dihydroteroate synthase during folate synthesis. However, when sulfonamides are present, they compete with PABA for binding to this enzyme and thus block folate synthesis. This is a classic example of an antimetabolite mechanism. An antimetabolite is a drug that resembles a normal metabolic substrate and interferes with its utilization. This explains both the mechanism of action and selectivity of sulfonamides or sulfa drugs toward bacterial cells. Having understood the folate synthesis pathway, we can now appreciate how different antifolate drugs interfere with this pathway at different locations. The term antifolate refers to drugs that inhibit folate metabolism and thereby disrupt the synthesis of nucleic acids and other essential cellular components. These drugs may act in bacteria, protozoa, fungi, or even human cells depending on their selectivity. Sulfonamides act early in the pathway by inhibiting the formation of dihydrotoroic acid. Trimethoprim and pyrimethamine act later by inhibiting dihydrofolate reductase. Methotrexate, in contrast, primarily inhibits human dihydrofolate reductase and is therefore used in malignant and autoimmune diseases. Sulfonamides can be classified according to their absorption characteristics and clinical applications. The first group consists of oral absorbable sulfonamides. These drugs are absorbed from the gastrointestinal tract and produce systemic antibacterial effects. Examples include sulfamethoxazole, sulfadiazine, and sulfasoxazole. Among these, sulfamethoxazole is the most important because it forms part of co-trimoxazole. The second group includes poorly absorbed intestinal sulfonamides. These drugs remain largely within the gastrointestinal tract and are used for intestinal diseases. Sulfasalazine belongs to this category and has a major role in inflammatory bowel disease. The third group comprises topical sulfonamides. These agents are applied locally to skin or mucosal surfaces. Silver sulfadiazine is widely used in burn patients because it helps prevent infection in damaged skin. Sulfacetamide is commonly used in ophthalmic preparations, while mafenide is another topical agent used in burn management. Although many sulfonamides have become less important individually, the class remains highly relevant because of the widespread use of co-trimoxazole, a combination of two drugs as we explain ahead. Most absorbable sulfonamides are well absorbed after oral administration. They distribute widely throughout body tissues and fluids and exhibit significant plasma protein binding. These drugs undergo hepatic metabolism, primarily through acetylation. The metabolites and parent compounds are subsequently eliminated through the kidneys. Because sulfonamides are excreted in urine, they achieve useful concentrations within the urinary tract, which historically contributed to their popularity in urinary tract infections. An important clinical issue arises from the fact that acetylated metabolites may be less soluble than the parent drug. Under conditions of dehydration or acidic urine, crystals may precipitate within the urinary tract. This phenomenon is known as crystalluria. To minimize this risk, adequate hydration is recommended during therapy. Another important point is that sulfonamides can displace bilirubin from plasma proteins. This effect contributes to the risk of kernicterus in neonates and explains why sulfonamides should generally be avoided during late pregnancy and in newborn infants. Sulfonamides exert their antibacterial effect by acting as structural analogues of para-aminobenzoic acid, or PABA. Normally, bacteria utilize PABA during folate synthesis. The enzyme responsible for this step is dihydropteroate synthase. Because sulfonamides resemble PABA, they compete with PABA for binding to this enzyme. When a sulfonamide occupies the enzyme, the normal reaction cannot proceed and folate synthesis is interrupted. As a result, the bacterial cell becomes unable to produce adequate amounts of tetrahydrofolate. DNA synthesis slows, cell division is impaired, and bacterial growth is inhibited. Notice that sulfonamides do not directly kill bacteria. Instead, they prevent bacterial multiplication. Therefore, sulfonamides are generally considered bacteriostatic agents when used alone. Sulfonamides are associated with several adverse effects. One of the most common problems is hypersensitivity. Patients may develop skin rashes ranging from mild eruptions to severe dermatological reactions. Among the most serious reactions are Stevens-Johnson syndrome, or SJS, and toxic epidermal necrolysis, or TEN, both of which represent two extremes of the same spectrum. These conditions are characterized by extensive skin and mucosal damage and may be life-threatening. The dermo-epidermal junction is the target, hence, one could see rash, bully, and sloughing away of the epidermis. Another important adverse effect is hemolytic anemia in patients with glucose 6-phosphate dehydrogenase deficiency, commonly known as G6PD deficiency. Because red blood cells in these patients have reduced antioxidant capacity, exposure to oxidant drugs such as sulfonamides can trigger hemolysis. Sulfonamides may also cause fever, urticaria, photosensitivity reactions, and other manifestations of drug allergy. When prescribing sulfonamides, clinicians should remain vigilant for skin reactions because early recognition and prompt discontinuation of the drug can be life-saving. In addition to hypersensitivity reactions, gastrointestinal adverse effects such as nausea, vomiting, and anorexia may also occur. Sulfonamides can displace bilirubin from plasma proteins. In neonates, this may increase the risk of kernicterus, a serious neurological condition caused by bilirubin deposition in the brain. For this reason, sulfonamides are generally avoided during late pregnancy, in breastfeeding mothers, and in newborn infants. These drugs may occasionally produce bone marrow suppression which manifests as leukopenia, thrombocytopenia, or megaloblastic anemia, particularly when therapy is prolonged. Renal complications include crystalluria and, rarely, interstitial nephritis. Maintaining adequate hydration reduces the likelihood of crystal formation. The overall message is that sulfonamides are effective and useful drugs, but their adverse effects require careful patient selection and appropriate monitoring. Now let us move to the second major antifolate antibacterial agent, trimethoprim. Unlike sulfonamides, trimethoprim is not a PABA analog. Instead, it acts at a later stage in folate synthesis. Before discussing its mechanism, let us briefly review its pharmacokinetic properties. Trimethoprim is well absorbed after oral administration and achieves high bioavailability. It distributes widely throughout body tissues and body fluids. One particularly important characteristic is its excellent penetration into prostatic tissue and prostatic secretions. This property makes trimethoprim useful in the treatment of certain urinary and prostatic infections. The drug is metabolized partially in the liver and eliminated primarily through the kidneys. Because urinary concentrations are relatively high, trimethoprim has long been useful in the management of urinary tract infections. Another point worth remembering is that trimethoprim crosses biological membranes effectively and can achieve therapeutic concentrations in several tissues. This broad distribution contributes to its clinical usefulness when combined with sulfamethoxazole. As we will see in the next slide, the real value of trimethoprim lies in the fact that it blocks a different enzyme within the same folate pathway targeted by sulfonamides. Trimethoprim and pyrimethamine inhibits the enzyme dihydrofolate reductase, commonly abbreviated as DHFR. Recall that after dihydrofolic acid is formed, it must be converted into tetrahydrofolic acid. This conversion is catalyzed by dihydrofolate reductase. The drugs block this step. As a result, tetrahydrofolate levels fall, and the bacterial cell becomes unable to synthesize sufficient purines and thymidine for DNA replication. The block ultimately inhibits bacterial growth by interfering with folate metabolism. However, the important distinction is that these drugs act later in the pathway. Another fascinating aspect of trimethoprim or pyrimethamine is species selectivity. Human cells also possess dihydrofolate reductase, but trimethoprim or pyrimethamine bind bacterial DHFR much more strongly than the human enzyme. This difference allows antibacterial activity while limiting toxicity to host cells. When used alone, trimethoprim or pyrimethamine is generally bacteriostatic. However, when combined with a sulfonamide, the antibacterial effect becomes considerably more powerful because two sequential steps within the same pathway are blocked simultaneously. Although trimethoprim or pyrimethamine are generally well tolerated, several adverse effects deserve attention. Both share many adverse effects. Because trimethoprim or pyrimethamine interferes with folate metabolism, prolonged therapy may occasionally lead to folate deficiency. This can manifest as megaloblastic anemia, leukopenia, or thrombocytopenia, particularly in susceptible individuals. One of the most clinically important adverse effects recognized in recent years is hyperkalemia. Trimethoprim can act in a manner similar to the potassium-sparing diuretic amiloride, reducing potassium excretion in the distal nephron. This effect is particularly important in elderly patients, individuals with renal impairment, and those receiving ACE inhibitors, angiotensin receptor blockers, or potassium-sparing diuretics. Patients receiving prolonged therapy may therefore require monitoring of serum potassium levels. Other adverse effects may include gastrointestinal disturbances, skin rashes, and occasional hypersensitivity reactions. Overall, trimethoprim is a relatively safe drug, but awareness of hyperkalemia is increasingly important in modern clinical practice. As we have discussed, antifolate drugs, including sulfonamides and others, interfere with folate metabolism. This raises an important question. What happens if excessive folate inhibition causes toxicity? The answer is folinic acid, also known as leucovorin. Unlike ordinary folic acid, folinic acid does not require reduction by dihydrofolate reductase before becoming metabolically active. Therefore, it can bypass the enzymatic blockade produced by certain antifolate drugs. One encounters folinic acid rescue in oncology more often, where it is used after high-dose methotrexate therapy to protect normal cells while preserving the anti-tumor effect. Recall that methotrexate is an antifolate anti-cancer drug. Clinically, folinic acid is used to reduce toxicity associated with antifolate therapy. It is particularly important in patients who develop significant bone marrow suppression due to prolonged antifolate treatment. The key concept is that folinic acid provides a way to restore folate-dependent cellular functions when excessive antifolate activity becomes problematic. Think of folinic acid as a rescue agent that helps normal cells recover from folate depletion. This slide compares trimethoprim and pyrimethamine. Take your time to learn. Like all antibacterial agents, antifolate drugs are vulnerable to the development of bacterial resistance. One important mechanism involves decreased intracellular accumulation of the drug. This may occur because of reduced permeability of the bacterial cell envelope or the action of active efflux pumps that expel the drug from the cell. Another mechanism is increased production of PABA. Since sulfonamides compete with PABA, excessive PABA production can overcome the inhibitory effect of the drug. Bacteria may also acquire altered forms of dihydropteroate synthase that bind sulfonamides less effectively. Similarly, resistance to trimethoprim can result from mutations in dihydrofolate reductase, reducing drug binding while preserving enzyme function. These resistance mechanisms explain why susceptibility testing may be necessary and why the effectiveness of individual antifolate agents can vary among different bacterial species and geographic regions. Interestingly, combining sulfamethoxazole with trimethoprim reduces the likelihood that a single resistance mechanism will completely abolish antibacterial activity. This slide introduces one of the most important pharmacological concepts in antimicrobial therapy, sequential blockade. Let us revisit the folate synthesis pathway. Sulfonamides inhibit dihydropteroate synthase, an early step in the pathway. Trimethoprim inhibits dihydrofolate reductase, a later step. When these drugs are used separately, each produces partial inhibition of folate synthesis. The bacterial cell may sometimes compensate and continue limited growth. However, when both drugs are administered together, two critical enzymatic steps are blocked simultaneously. This dual inhibition dramatically reduces tetrahydrofolate production and produces a much stronger antibacterial effect. This concept is known as sequential blockade because two consecutive steps within the same metabolic pathway are inhibited. Sequential blockade represents a classic example of pharmacological synergy and forms the scientific basis for the combinations of antifolate drugs, for example, antibacterial co-trimoxazole. This diagram visually summarizes the concept of sequential blockade we have just discussed. The result is a profound reduction in folate availability. An important clinical consequence of this dual blockade is that the combination often becomes bactericidal, even though each individual component is usually bacteriostatic when used alone. Now we will discuss an important fixed-dose antibacterial combination co-trimoxazole, which includes sulfamethoxazole and trimethoprim. Together, they produce sequential blockade of folate synthesis. Individually, each drug is usually bacteriostatic. However, when used together, the combination frequently becomes bactericidal because bacterial folate synthesis is suppressed much more effectively. This slide also summarizes the major clinical uses, adverse effects, and monitoring requirements. Cotrimoxazole is generally used when an organism remains reliably susceptible despite widespread resistance to many other antibacterial agents. One of the most common uses of cotrimoxazole is the treatment of susceptible urinary tract infections. High urinary concentrations contribute to its effectiveness in this setting. Another extremely important indication is pneumocystis jirovecii pneumonia, often abbreviated as PCP. Cotrimoxazole remains the drug of choice for both treatment and prophylaxis of this infection in many immunocompromised patients. Cotrimoxazole is also considered the drug of choice for nocardiosis, an infection caused by Nocardia species. In recent years, it has gained importance in the treatment of community-acquired MRSA skin and soft tissue infections. The drug is also active against several important respiratory pathogens and certain opportunistic gram-negative organisms, including Stenotrophomonas multifilia. This slide brings together the entire lecture into a single comparative framework. Notice how each drug acts at a different location within the folate pathway. This comparison illustrates an important pharmacological principle called species selectivity or target selectivity. Drugs can target the same biochemical pathway while exhibiting completely different clinical uses because of differences in enzyme selectivity. Before concluding, let us briefly review the most important messages from today's lecture. First, bacteria synthesize folic acid, whereas humans obtain folate primarily from dietary sources. This difference provides the basis for selective toxicity. Second, sulfonamides are structural analogues of PABA and inhibit dihydropteroate synthase. Third, trimethoprim inhibits dihydrofolate reductase. Fourth, combining sulfamethoxazole with trimethoprim produces sequential blockade of folate synthesis and results in synergistic antibacterial activity. Fifth, cotrimoxazole remains clinically important for urinary tract infections, pneumocystis jirovecii pneumonia, nocardiosis, community-acquired MRSA infections, and several opportunistic pathogens. Finally, remember the major adverse effects. Sulfonamides are associated with hypersensitivity reactions, Stevens-Johnson syndrome, toxic epidermal necrolysis, crystalluria, and hemolysis in G6PD deficiency. Trimethoprim may cause folate deficiency and clinically significant hyperkalemia. We have now completed our discussion of antibacterial antifolate drugs. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!